Welcome everybody to the first of our four country panel series. My name's Ivy Bourgeot. I'm with the Canadian Health Workforce Network, and I'm very pleased to host on behalf of the network this IHWC series of country roundtables. We haven't met since October, the fall of 2019. So it really is wonderful to have everybody together and to hear lessons learned through the pandemic. I'm coming to you from the city of Ottawa, which is the unceded, unsurrendered territory of the Algonquin and Anishinaabe First Nations people, Quay, and to whom I pay respect. And with that, I'm going to pass over to Nick.
Thanks, Ivy, and hello, everybody. It's great that you can join us today, whether you're joining us in the Southern Hemisphere or the Northern Hemisphere, and just want to echo the comments of Steve that it's so nice to see some familiar faces again after so long not being able to see you. I also want to start this morning by acknowledging the traditional owners of the land that I'm on today here. I want to acknowledge the Yagara and Turrbal people. Their lands are in the southern parts of Queensland. I want to acknowledge their ongoing connection to land and sea and community, culture, and pay my respects to their elders, past and present. Look, today we are aiming to have what we hope is an informative and participatory conversation and reflect a little bit on what we've seen in terms of our healthcare and our health workforce models in Australia and New Zealand through the pandemic. I'm joined by three panelists and I want to introduce them to you. First of all, I want to introduce Professor Sabina Knight. Sabina is the director of the Central Queensland Centre for Rural and Remote Health with James Cook University, which is primarily based within the central and northern parts of Queensland. Welcome, Sabina. Also would like to introduce Emeritus Professor Des Gorman. Des is from the School of Medicine and University of Auckland, and also would like to acknowledge and welcome Chris Robertson. Chris is the Executive Director of Strategy and Policy with the Australian Health Practitioners Regulation Agency. So welcome to you all. We wanted to start today in terms of setting a little bit of a scene by playing just a couple of excerpts from a recent national conference that we held in Australia. And in these excerpts, you're going to hear some comments from a policymaker and from a representative of the Australian Medical Association, so a professional body representative, as well as from a consumer representative as well. And for me personally, I find the comments of the consumer people to be probably the most incisive. But I thought I'd play these three for you just to get a bit of a sense of the Australian flavour. Thanks, Ivy. Over to you.
So all of our workforce issues got worse under COVID. Getting health workers into rural and remote areas, reliances on overseas workforces in certain areas, geographies and practice areas was seriously curtailed. And we needed to work on the flexibility in healthcare workers' practice and scope of practice and their relevant credentials. So we've learned a lot about flexibility in clinical roles. How can we quickly flex up our workforce by utilising them in different settings, or quickly training them up to work in different areas? And certainly the creativity around the vaccination workforce would be a case in point. In this respect, we've turned our focus to an emphasis on skills and professional capabilities, not professional titles or traditional silos. This will be challenging for some professional organisations and relevant partners in the system, where traditionally they've seen certain areas of practice as their protected domain. Although this is not so much a regulatory problem, the regulatory system needs to support an overall risk management approach, which is not based on professional silos, but on skills recognition and capability development. So this is not to say that traditional health worker professions will not continue. Of course they will. But the way the professions work together and recognise the skills of each other needs to be flexible. As well as clinical risk, there is the risk that some strategies we try will not work. If we try and stand up retired practitioners as an emergency workforce, for example, there is not only the risk that these practitioners may make mistakes, but also the risk that the initiative will not deliver what we think it will deliver. And I guess we did experience nationally that it turns out not all retired health workers wanted to come back to work in the system in a pandemic. So as a result of all of this, there is a risk of losing public confidence in the health system. And we know that we have to maintain that confidence so our public health strategies will continue to work. It's the balance between trying things that don't work and risking loss of confidence, or risking loss of confidence by not trying anything at all. There is much talk in the media and globally about the Great Resignation. And depending on which study you follow, there's the idea that once we get to the end, so-called, of the pandemic, even noting that we don't know when that will be, that's when people make decisions to change their careers. We are not seeing that in significant scale in our data at the moment. We have some slightly elevated numbers of resignation over the January period, but that's a seasonal factor we normally see. And of course we did unfortunately have to part ways with over 1,000 staff associated with non-compliance with the mandatory vax public health order. So we're not seeing it yet, but we remain concerned that we might. And we can always seek to add more graduates, more students, more interns, and we've sought to do that particularly with nurses in our recruitment rounds recently. But we can't lose an effective skill mix from experience to mid-level experience through to new staff in our clinical teams. And I guess the last point then in the reckoning is we don't yet know what the long-term health effects will be on the population of having COVID in the community to such a scale, and hence on our health systems. What will be the effect of delayed clinical services, delayed treatment, delayed diagnosis, or the effect of public health staff and other staff who've been diverted to urgent COVID response work, and how this has affected business as usual in normal public health strategies, such as screening and prevention and other infectious disease programs.
There's been a lot of press during this pandemic about the constant pressure of frontline staff, and certainly within the medical workforce, that has certainly been the case, from the doctors in hospitals to the GPs who've been inundated trying to balance regular patient load with COVID care while trying to vaccinate to the greatest degree, to psychiatrists who've been sort of overwhelmed by the number of patients and the great need that is out there at the moment in terms of psychological, psychiatric of needs, and also the surgeons who have had such an off again time in terms of trying to provide care for the patients, and now face a very uphill battle to be able to catch up on the care for their patients. I have conflict of interest, being involved in the My Health Record for many, many years, and being a clinical reference lead of the Australian Digital Health Agency. And right through that time, we've gone from this position of, why should we do this, and hearing all the problems, to the shift that the pandemic has shown of why not, and why haven't we had this beforehand. So there is a lesson in this. There's a risk of doing something, but there's a risk of not doing something. And I think that is something we do need to consider. Having said that, I think it's really important to understand what these have been. These have been tools to improve care. And there is this foundation on which they're built on, which is still that care is based on decades of training and experience and people who are skilled. These have been tools to get the care there, not the care in itself. And the AMA is concerned, and you won't be surprised, that there's this concern about the cheapening in focusing just purely on convenience, not understanding that we still need to hold to the foundations of high quality care and high standards.
And over the last 5 years, I've built connections and friendships with many patients in Tasmania and across Australia. My own concern for patient safety has diminished in the face of their deep and utter desperation for patient access. I would not be doing my job today and representing them if I did not put to you their call for greater access front and centre of this presentation. I'm just going to share a screen for a second so that I can show just a little bit of a PowerPoint that I've got. So on this PowerPoint, I've nominated 3 topics that health consumer advocates are most worried about going forward. Firstly, as a result of COVID, we are seeing increasing inequity. COVID has ripped off some of the band-aids that have been holding us together. And what was once just difficult for those at the margins is now becoming difficult for many. The role of health regulation is difficult in this context. You want to keep people safe, but what if the rules if you've created are setting the bar so high that we can't actually afford to get access? It shouldn't have to be either or. We tell ourselves we have universal healthcare in Australia, and it's only in America that becoming sick will make you poor. The reality in Australia is that healthcare costs money. It isn't free for patients and carers, and the costs are becoming harder and harder for a growing number of people. And there's every chance health technology will increase this divide between those that have and those that have not. Which brings us to community engagement. We've learned through COVID that our responses to health emergencies are only as effective as our inclusion of people who are most at risk. Their voice must be at the table, both informing and sharing in the decision-making. While community members on boards and committees need to be independent and non-practitioners, they also need to be the voice for those people in our community who most need healthcare services. If we reflect on the Patient Charter of Rights, and if we listen to what patients are saying, particularly those with limited resources, they are absolutely begging for access. Over the last 4 years, I've worked to help establish Health Consumers Tasmania. I've met with countless patients and carers across the state, and through the Consumer Health Forum of Australia, I've met them interstate as well. I've heard their stories and they've heard mine. The hardest stories I've heard through COVID have been from Northern Tasmania. They're from single women in their 40s and 50s and 60s. They've chosen to become foster carers. They suffer chronic illness. They're trying to care for foster children who are overcoming trauma and sexual abuse. The women can't get access to mental health services for their kids, and they can't get access to help for their own conditions. I cannot describe to you the fear and desperation I hear in their voices as they confronted COVID and its impacts. And so, while I personally have always had an interest in patient safety because of my lived experience, and I've tried to pursue the topic with others, I can't actually get the conversation there with these people out in the field because they're so concerned about access. I've run 2-hour workshops with patients where we go through the Charter of Healthcare Rights, as per this PowerPoint, but I can hardly get them past point 1. That's all they want to talk about. They're consistently telling me they can't get appointments with health practitioners. If they can get an appointment, the wait list is crazy. And if and when the appointment finally does come, they can't financially afford it. Unfortunately, I think it's a pandemic for Emeritus to start thinking about what has, for a very long time, been the highest concern for those patients and carers who most need your help. The issue of access is now so large that NRAS must pursue it with priority. We need you to pull what levers you can. And trying to backfill the existing workforce within current scope of practice might not be the answer. At local community levels, our consumer leaders have a lot of solutions that look like community-controlled health responses, similar to Aboriginal community-controlled health organisations. And they look to make increasing use of assistant practitioner roles. But for these strategies to work, we need established health providers in a community to be willing to share their wait list and redistribute the risk. How can we do that in a private economy, apart from appeal to goodwill? The problems can feel overwhelming, but as patients, we ask you to put your mind to these issues because our hardest times are probably ahead of us. And you, our dear, dear health practitioners, have proven through the pandemic to be absolute superheroes. No pressure, guys. Sure, you can do something about it.
Oh, thanks, Ivy. I'm going to now go and turn to our panelists that I introduced before. And the first question I've got for our panelists is this. During the pandemic, what have you seen in health services that you would say was innovative or a good flexible use of health workers? And what made these innovations successful? Or indeed, if you saw some that were not successful, what were the factors that made them unsuccessful? And I'm going to start with you, Sabina, and then go to you, Des.
Nick. Hello, everybody, and I'd like to acknowledge the Western Kungaloo people on whose land I am now working on. You might have noticed I've changed address. Some of the things that I observed have really been picked up by those previous speakers, so that it was stark how quickly we saw health system integration and collaboration improve during COVID. And from a workforce perspective, really underpinned by some flexible work arrangements. Previously, our system is quite inflexible, really, and the desperation for workforce drove flexibility, and everybody benefited. That empowering staff to work to their full scope of practice, and the new models, we saw allied health use the transferable skills, expand some of their skills in the COVID testing, and that many were trained in prep for the vaccination clinics, but I don't think were fully utilised in the vaccination effort. We had a brief, although it didn't feel brief at the time, during the 2 years, a period of less red tape that everybody celebrated enormously. And importantly, increase access and sharing to data. So if you remember, in Australia, our healthcare system is that we're a federation. We're sort of the opposite of Canada, and your provinces, we're states, but our federal government subsidises primary care, and the state governments run hospitals. And there's private sector across all of that, and then aged care. So we've got the fragmentation. We've got a pretty good system, but still lots of fragmentation. And we saw vast improvements of that. And the glue that really pulled that together was virtual care, the ability to deliver care virtually and be able to respond to people's need for access of care was critically important. And that really did impact in the those who were more marginalised, or those who were geographically more isolated, who would normally have to travel for care, be able to get it. And in rural and remote areas, using technology to support the delivery of care is not new, but this really did improve things. So I think those things were pretty important. The no surprise was, or the big reveal was the vulnerability of services were absolutely revealed during COVID. And so we've seen small remote clinics close down, people go without services because there just isn't enough staff, and that's really sad. And it's a diabolical situation because we have an over-reliance of interstate workers and international health workforce, people travelling from Asia and New Zealand to remote areas in Australia, and not being able to do that during COVID. So they're the things that I observed. I think those new roles, just as a small vignette, up in Northwest Queensland, we run a community rehab program with students. It's a really successful program, and we kept that going during COVID, and we switched to telehealth. We still did face-to-face for those very vulnerable, those immediate post-discharge stroke patients, one-on-one, so that to reduce any risk to them. But we had students and their supervisors dotted around the building doing one-on-one tele-rehab with those patients, and it worked incredibly well. And we had to overcome things like, purchasing devices for patients, but that was easy to do. We're not talking about hundreds of patients. It was a much smaller number. But we were also able to absorb more students so that we were doing our bit towards those allied health students being able to graduate at the end of that year, and and not being held back, and that was important as well. But it did highlight to us the importance of those telehealth skills as the essential skill mix in our health workforce. So I might stop there. I've got a few other observations, but I'll hand over to Des.
Kia ora tātou, ko Des Gorman, tako ingoa ka ngāpui tako iwi. Much of what I have to say is just to echo what you've just been saying, Sabina. We had a very similar experience, although COVID in New Zealand was never at the extent that you experienced in Australia or in North America, in the United Kingdom. We are having about 10 deaths a day at the moment, but we shut down to such an extent that while it's caused severe damage to our economy, we've managed to keep the COVID pandemic within the constraints of a very limited health system. Yes, there was some need for adaptability, and there were transfers of people into non-traditional roles, but I think, Nick, the outstanding innovation has been the shift from consultations from face-to-face to other mechanisms, and the lift in productivity that's achieved. And hopefully we won't go back to the old days. For example, I do 3 clinics a week, of which 2 are now virtual and only 1 is face-to-face. And when I look at the patients that have been referred to me, I choose the ones that I think I need to see face-to-face. And that's usually because I think I need to examine them to make some sensible determination. What this has done is improved access, it's improved throughput, and it's obviously hugely convenient for the individuals who don't have to take a half a day off work to come and see me at the hospital. In regards to the videos we saw, I have to agree entirely with the comment around access. Access has been the single biggest cause of unmet need in New Zealand for a long time, manifest as the unavailability of the doctor that the person wants to see. The other issue I'd have to reflect is that what we have seen through COVID is that the shortages and crises we thought we had in the workforce were probably worse than what we thought. And we are really staring at a very profound problem with retaining nurses in the workforce. Even before COVID, half of our nurses were either planning to retire or give up nursing or go to reduced hours. And there's nothing happened in COVID that's going to encourage them to stay, quite frankly, because they were worked mercilessly. So I think the challenges that we knew we had before this pandemic are now in stark contrast. And I'm hoping that the political will that didn't exist to address problems in, say, palliative care, mental health, public health, intensivism, and so on, I hope those reservations may now resolve. But thanks, Nick.
Thanks, Des. I might go over to you, Chris.
Thanks very much, Nick, and good to see you all again. I'm joining you from the lands of the Turrbal and the Yagara people as well. So look, just building on what Sabina and Des have said in the videos, I think, and as you know, I'm from a regulatory space, so the red tape words came up already. I think I just want to highlight a few different things, because I would say I think we've seen huge innovation in our country and health workforce, some of which I think has been very good and some of which has been disastrous from the point of view of sustainability. And I think Des and Sabina have already touched on this, and so did some of the presenters in the videos. So we returned over 40,000 retired, in inverted commas, practitioners, so people who are non-practicing or otherwise formally registered, back to being able to work as a registered health practitioner or to practice. They did have to meet some requirements, but not the usual requirements of registration, and they also didn't need to pay for that. So we had, similar to what we understand from the research and evaluation from other countries, we probably had around almost 10% of those people return to practice at one point in time over the past couple of years. We're down to having about 20,000 people on this register now, and it is a temporary register. And I think it's been very helpful, but in very limited circumstances. So a pharmacist in a particular rural location that was locked down, where someone's actually been able to deliver services for 4 or 5 weeks that otherwise would not have occurred. So quite important, but limited return on investment, if I could put it that way. And probably come at quite a cost to some of the individuals in the stress sense, which is what I wanted to pick up really, because I think I've seen a number of anecdotes, some of which are in a book that's just been released by Professor Marie Bismarck, who some of you may know is an Australian New Zealand researcher and psychiatrist and a number of other things, as well as a legal practitioner. She's done online surveys, I think, of over 10,000 registered health practitioners in our country, mostly frontline workers. They tell, you know, an horrific story, I guess, of their experience over this period. Some great innovations, but likewise, some examples where we know we've had nurses, for example, go into the healthcare setting that they normally work in. They may be a graduate nurse, not particularly familiar with intensive care, and they've then spent the next few weeks of their working life working in intensive care in situations that they have reported as feeling, you know, not in control, not feeling safe, and so on. So I just want to use that perhaps as an example to say, I think the sustainability, as Des and others have already raised, then of that impact on, let's say, innovation in the workforce in a crisis context has been quite disastrous in some cases. We've got reduction in hours for many people. So I think that is going to exacerbate the access issue. And probably just as a personal note, I know my own GP, who doesn't take any more patients and hasn't for years, works until about midnight regularly now, thanks to telehealth, because I think they do the face-to-face consultations during the day, and then from 6 p.m. onwards till about midnight, as I understand it, that is actually the telehealth consultations. And so I guess some great flexibility and innovations around scope of practice, but I guess the sustainability side of it's going to be quite critical for all of us. I'll finish there. Thanks, Nick.
Yeah, thanks, Chris. And look, sustainability keeps coming through in the themes of this discussion rather than just flexibility. So I'm going to frame my next question a little bit sort of differently, and just to say, well, you know, what do you think in terms of any innovations do you think that need to be embedded or sustained over, you know, over the coming years as we come out of the pandemic? What are the opportunities to do that? And then I might ask people as well, I've just seen the sort of query from Ivory about the reasons for exits for nurses, and some of them to some degree I suspect have already come up, but I'm going to check in with the panel again about Ivy's question about that. What are the reasons for nurses and indeed other health practitioners to consider exiting? So I'm going to ask you, Des, first for a comment, and then I might go to Chris.
Okay, thanks, Nick. The answer to your question, Ivy, we do have some data on this. One of my PhD students actually interviewed several thousand nurses, and the reasons why they are unhappy is the lack of autonomy, the lack of flexibility, the problems in mixed childcare. But what really makes them upset is the fact that they don't believe they're providing the quality of care to their patients that they think they should. And that's because of, although we are sticking to safe patient ratios, the patients are older, sicker, and have multiple comorbidities. So they're a much more demanding patient community than when those safe nursing ratios were determined. So with a lack of autonomy, a lack of flexibility, conflict with their lifestyle, and then a sense of not providing good quality care to their patients, this manifests in demands for increased pay and all sorts of things. But frankly, Ivy, that's not the problem. The problem is a core lack of satisfaction in their job. As to your other question, Nick, about sustainability, there are two key issues in healthcare at the moment. One is sustainability, the other is value. And I noticed this year, the International Federation of Health Plans, which are all the private insurers, I'm one of their speakers, that whole conference is dedicated to sustainability. And you can see sustainability, Nick, either in ecological or environmental terms on the one hand, or you can see it as how do you sustain health services where the inflation in the cost of delivering that service doesn't impact on consumers to the point they change their insurers, or in the sense of public systems, the cost of healthcare crowds out other core government funding like education and social welfare. So the sustainability challenges are protean and formidable. And really the solution requires it won't be solved by restructuring, it won't be solved by changing remuneration methods. It requires a complete reimagination from a sickness and injury management system to a health system. It requires a shift to, as much as possible, fully forward funding healthcare rather than transactional funding of healthcare. And it requires, in the case of public health systems, a social commissioning approach where all of government focuses on the high risk communities, whereas in fact, as you know, at the moment, in any public system, you have silos of education, welfare, housing, justice and prisons and so on. And I have to say that one of the most successful programs I'm overseeing at the moment is for young Maori and Northern, my relatives, with mental health problems, where we're not employing any psychologists at all, none. But what we are employing is people who can find them a place to live with some dignity and a job. And that's having a profound effect. Of the first 100 we put through that program, all but 3 have given up their pee habit. So the whole question about sustainability, Nick, is getting upstream and dealing with the social determinants of disease. The simple reality is that sickness and health management systems, as compared to health systems, are not sustainable.
Great, thanks, Des. I'll go to you, Chris, to see if there's anything you wanted to add, and then I'll go to Sabina.
Thanks, Nick. So just perhaps to take a different tack from Des, because I absolutely agree with everything he said, but just to maybe focus in then on innovation and change that's happened around scope of practice within the registered health practitioner context. So I think we've seen some examples similar to what Des has raised then around vaccination, for example, where if I just say the registered health workforce has got quite a structured set of limitations in what it can and can't do around vaccination. Interestingly, 1 or 2 of our large jurisdictions that have quite a degree of remote population actually moved to authorising people with no clinical skills to administer vaccines under supervision of a registered health practitioner. And I guess the reason I raise it is it goes right to the issue of what type of skill do you need for what type of role, particularly in the middle of a significant crisis. And we found ourselves in situations where we were answering phone calls from large health departments who, due to some changes perhaps in their personnel during the crisis, were particularly unaware of what types of skills might be required for what types of things. For example, contact tracers. At the point in time that was relevant, we had health departments advertising for registered nurses to do contact tracing. And when we asked them, do you need to be a registered nurse to do that? The answer was no. And, you know, the obvious question then was, well, why are you advertising for them? Because we know there aren't any available. So I think we've seen some interesting examples of where people have had to actually understand what is the scope of practice that can be used in the most effective, efficient way. I would like to see some of those things continue to be put in place. And obviously pharmacists, my experience of going to a large vaccine hub to be treated by, you know, a registered nurse, and there were many of them and many other people there, compared to going to a pharmacy for a booster where there was 1 pharmacist and 1 assistant, and it was very effective and efficient, and I was very pleased with the service. And, you know, I think even just from an access and user experience perspective, we can see those barriers that we did have in place and possibly will return to. And, you know, we've got some live turf wars happening right now, if I could put it that way, specifically around pharmacists and prescribing for the future and other professions. I think that innovation in scope of practice that was permissible and necessary during the pandemic would be something that actually is fundamental for sustainable health services. And I'll come back in the next section just to talk a bit about community control, though, because I think there is, that's an important element of this, and linking back to what Des has already said, I think. Thanks, Nick.
Thanks, Chris, and thanks to people for putting some good comments into the chat box. Would really encourage you to keep doing that. Thanks to Steve and to Sue Skillman. Great to hear from you as well. I'm going to go to Sabina.
To answer your question, Steve, in Australia, nurses can vaccinate. In the primary care sector, you will either go to your GP or your family physician, where they may vaccinate, or more likely their practice nurse. You can go to a pharmacy for your flu vax, and now for your COVID vaccines, thank heavens. So there's a variety of settings where you can get vaccinations, but there are different requirements in different states that Chris alluded to. In Queensland, you have to be, as a nurse, you have to be endorsed to vaccinate. This has become a big industry, so you have to, at great cost and quite a bit of time, study a certificate of immunisation, which I have said for a very long time is completely unnecessary. When we agreed through COAG to improve our vaccination rates in Australia, and we set up education courses and a way of endorsing people or around the country, it was largely a weekend course. Now, I'm not saying that flippantly. These are registered health professionals who have got all of the transferable skills and the basic knowledge. They just needed some more. And now it is way too big, and it puts people off. And it means that access issue comes up a lot. So prior to COVID, a lot of people, particularly children, did not get vaccines in a timely way, and in more rural and remote areas. And this was completely, there's a veneer over this that we just don't see. And we can change that. And it's hard to wind stuff back. And we wound it back a bit during this, but we've seen also an explosion of education providers, into people getting on the bandwagon. And whilst some states don't mandate, you have to be endorsed. They say you have to do a course, but you don't mandate board endorsement or endorsement. It's a bit easier to manage. And so trying to get some consistency across the country would be good. But we've over-engineered it. And we also over-engineered, as you said, who had to be there when you were having the vaccination. So we diverted too many precious health professionals into vaccination clinics and same with COVID testing clinics, where we really needed them at the acute care setting. And so that's a lesson learned for us. We are very, very risk averse. We've got a single dimension view of risk. That's what happens if something goes bad. The other dimension of risk is what happens if people don't get access, is not measured at all. And so we really need to come to terms with that. And now I completely headed off into the tangent. For those of you who know me well, we're not at all surprised. So Nick, what was I answering?
Oh, look, I just wondered whether there's anything you wanted to continue to embed post-pandemic.
Absolutely. I think that the health systems under pressure, when everyone's got a common purpose, do devolve by necessity decision-making down to a local level, and empower people to work to their top of scope. And so I think that is critically important to try and work out how to embed. We've already seen a bounce back where that we've moved away from that, but I think that's really important. And that focus on consumers, as health professionals, and preparing a workforce to be able to provide quality of care, that focus on consumers really does shape how you provide services and gives you a license to be able to be creative. And I think that's really important. So the whole health equity agenda is critically important. Those who've missed out during this time, who were already behind, are going to be way behind. And so we need to make sure they receive their services first, and then we just don't restart the queue from where it stopped. And so to embed that decision-making and that flexibility to working to top of scope and transferable skills. And the other thing we all did is we used students, particularly final year students, as part of the workforce, which we've always done, but not recognised it. And so, they're not fully full participants in the workforce, but they have very useful skills they can continue to be learning as they go. And where health workers are going to be learning forever more. And so I think we need to be less concerned about what they need to know the day that they register. And we put a lot more scaffolded support around them to try and reduce that pressure on themselves and others around how they think they're coping in those really difficult environments like ICU that people talked about.
Great, thanks, Sabina. I'm going to pick up on the comment from Sarah Simpkin, and I might start with you, Des, and then go to Chris. But Sarah was reflecting on sort of the question of who should be seen virtually and for what, and how well has that kind of been sort of thought through, how well has it been codified, how well are the sort of guidelines and directions given to health professionals to undertake that. And I might ask Des, have you got a comment on that? I mean, I know it sounds like you're already doing some telehealth work yourself. And what about you, Chris? I'll go to Des first.
I'd like to as well.
The answer, Nick, is I do a lot of my consultations now through video, and the decision to see someone face-to-face is where I think the face-to-face encounter and an examination will add value, where I think it's necessary in terms of formulating a treatment plan, or where I think it's going to require face-to-face consultation to actually get someone to take up a particular treatment option. So face-to-face is not my default option. My default option now is doing it by video, and there's got to be some reason why I go face-to-face. From a value proposition, Nick, the best example of this is probably Kaiser, who found that their customers were very unhappy about having to take a half a day off work to go and park in their building, to pay parking, to wait to see a doctor for a completely predictable encounter. And they found the doctors were unhappy because they were spending most of their day with processed stuff, and they had very little time to look at people who had quite complex, undifferentiated disease. And the funders weren't happy because they were building more bricks and mortar. So in 1 year, they shifted 50-odd million face-to-face consultations to some sort of alternative delivery, email, text, video, and so on. And there were reasons why they did that. One is they had clarity around their customer experience and expectations. And by customers here, I'm talking about not just consumers, but providers and so on. The second thing is they were concerned not to end up with high technology solutions for low technology need. And I'll give you an example. If I have a patient who's got petit mal epilepsy and I want a child and I want them to take valproate every day, I don't need a computer algorithm. I just need a text message each day which says, give the kid the pill. And the message keeps going until they send a message back showing me an empty blister pack. So that's a low-tech solution for a low-tech need, but it attends to one of the major issues in primary care. I'm not a primary care physician, I'm a hospital physician, but it attends to one of the major problems in primary care, which is compliance. So the answer to your question, Nick, is I believe I should have to generate a reason why a face-to-face is necessary, because it'll add value to me and to the person I'm seeing. So I'm trying to get my head around what the value proposition looks like in any particular encounter. And I have to say that the lift in productivity by doing it virtually and seeing only the people I think I need to see is quite significant.
Great, thanks, Des. Chris, what about you from a regulator's perspective? I know we've got some of our boards have got guidelines about using telehealth services, but are you able to comment at all on sort of whether or not what changes we might have seen in sort of regulatory profiles and outcomes as with telehealth through the pandemic?
Yeah, thanks, Nick. Look, just quickly, so I'd say probably at least two areas seem relevant from a regulatory point of view, and building on what Des has said. So I think the default in our country is not telehealth, particularly in the funding side of things. So there's I'll just channel what Sabina's already said about risk aversion, because I think that's relevant right now. So our default is not telehealth or virtual care in most cases, although there are some excellent examples, I believe, of, for example, psychiatry using text messages and mobile phones as a model of care, similar to what Des has already alluded to. So I think Where the funding enables it, that can work very well, and the value proposition's definitely there. I think from a regulator's point of view then about the guidance, I think we're trying to encourage people to use virtual care in, you know, following all the good medical practice, if you're a medical practitioner or any other health practitioner, in the way that you deal with informed consent and all the other things that you would need to do, but in a virtual context, and how you apply that. So I think, Nick, I would say we're trying to remove any regulatory barriers. I would say most likely, though, the biggest barriers, I think, are custom and practice, and then the funding barriers rather than other areas. That's it from me.
Thanks,
I
Chris.
think
What
that's
about
interesting, Chris? Because I would disagree with you, Mike. Just in that last point, I would say the biggest barriers are not the customers. The consumers really like it. They'll tell you when they don't and why, but they much prefer timely access, and they're usually way ahead of the game. And when it comes to virtual health services or telehealth services, but it is
Sorry,
practice.
Sabina, I should clarify, I said custom and practice. So I actually think it's entrenched behaviour because I agree with you. I think customers, including myself, very happy with it.
Yeah, that you're right. It is practice, and there's a huge resistance, which clearly got snapped during COVID, which was great, to virtual care and to telehealth. And we do need to get the funding models right. But certainly in the private sector, I'm aware of a whole raft of private allied health professionals and some private nurses, as well as private medical practitioners across a whole raft of specialties, general practice, who use, because they're able to bill themselves or whatever arrangements they have very successful virtual practice, but it can only then service that niche population. But absolutely we're right for it, and I think that it is the one thing that I don't think that consumers of healthcare will let us go back from, in that they will continue to lobby. Ivy, I saw your question around violence and safety. I don't know that we've seen an uptick in violence in mainstream services, more than usual. There's a bit of frustration, but not more. And we've seen some in remote services where people are pretty frustrated about being isolated. We've had some pretty awful events over pre-COVID, and a real drive to improve, particularly after hours services and the safety of the workforce. And there's been quite a variation in how those strategies have been taken up. And we've got some research around that at the baseline now around how that is and how the clinicians view the implementation of safety strategies. And I'd say watch this space. It is something that we need to do a lot more of. And one of the wonderful things about this absolute rapid pace of technology is that so many things are being developed and evolved that will assist our workforce wherever they are, and particularly in remote areas. And it's how do services keep pace with that. But I think that the focus is on really and truly valuing the health workforce, then they'll do it, and respecting them, and really and truly valuing the consumers and respecting their rights and needs to have access to care where and when they need it. And those two drivers should, together with the appropriate funding, drive the uptake.
Look, thanks, Sabina. Look, I'm going to ask this as a final question, and then perhaps go on to sort of finish by any other comments that our panelists would like to make. But I'm going to ask these panelists, if you had to name one thing that the system should invest in to keep flexibility in our workforce, and I'm going to drop sustainability in there as well, given that we've talked about it so much, what would be the one thing you'd invest in? And I'm going to go with you, Chris, and put you on the spot first.
Thanks, Nick. And thanks for letting me know what the question was beforehand. So I have thought about this, and I'm going to approach it probably more from a governance perspective, which is, I actually think community controlled health services is picking up what Kate Griggs said earlier on in the video. I think examples where we've got community controlled services that are governed and work in the interests of the community that they serve. So for some of our Aboriginal and Torres Strait Islander community controlled services, they did a brilliant job in, healthcare and prevention in their communities because they're known and trusted and they provide culturally safe healthcare. We've had some stunning examples where that didn't work well, where we sent in military, medics and a whole range of other things into communities, and there would be, the examples I've heard of is, people trying to do great work, but there was one group of practitioners there one week, a different group of practitioners there the next week, and none of them were seen as trusted, safe, familiar people to the community. So I think interprofessional education, interprofessional collaborative practice, and when I say that, I mean more than health practitioners. I mean the true sense of patient-centered care as actually being the skills that are required. And I think we've got a duty then to educate health practitioners and change the healthcare system so that community controlled or community engaged, involved is actually the default model. We're a long way from that in our country, I would say, in most healthcare, but we have some brilliant examples where it can work well. And I think there's a lot we can learn in mainstream healthcare from that. That's it from me, Nick.
Thanks, Chris. I'll go to Sabina next and then on to you, Des.
I think whatever we can do that will integration and maximising the effectiveness of the workforce. So I think if we work with consumers around electronic health records, for example, that they've got control over that overcomes fragmentation of service. So it doesn't matter what door you come into or who you see, at least your health summary's there, and you can move through your providers as need be. My own observation is that the clinicians are not using the capacity in our current electronic health record system, and so we've completely missed that opportunity. Been so politicized, and we've really got to get past that, and supporting people to work to the top of scope, and calling out the shroud waving, and we've really got to be able to do better than this, and with total respect for all of our workforce, because they are tired, and we just need people to be as good as they can be where they need to be, and supporting people to not imagine barriers where they don't exist.
Thanks, Sabina. Des.
Nick, if I had to choose one thing, I think that was your directive. If I had to choose one thing, the area would be primary and community-based care. I don't think there's a great deal of productivity gain within hospitals, whether I go to Massachusetts General Hospital or Melbourne Women's, or I go to a hospital here in New Zealand. Hospitals are hospitals. They pretty much run the same way. The models of care are pretty similar. Clearly, Massachusetts General would have more technology and better staffing than some of our hospitals, but in fact, the operating models are very common. So I think while in hospitals there's some gain from economies of scope and economies of scale, they're modest gains, whereas in primary and community care, the diversity of models of care and the diversity of funding mechanisms and the diversity of delivery systems is such that there's very clearly significant opportunity for uplift, and particularly if you consider the uplift possible by getting greater engagement of people in the community in regards to their healthcare. What's holding all this back, Nick, and where would I focus? Literally, it's the funding models. I think the funding models are constraining workforce diversity, constraining new models of care. The funding models, particularly in some of your countries like Australia, are transactional. They lend themselves to activity-based funding. If you basically have a menu of services and you stick to the menu because that's what you get funded for. It doesn't lend itself to discovery of better ways of going about providing healthcare. If there's no Medicare benefit schedule item for it, well, why would you do it? So I actually think there's a revolution needed in funding models to enable new operating models, which really rely upon a greater diversity. And the sorts of diversity I'm talking about are some of the success we've had with just-in-time trained micro-credentialed health workers. someone who's trained to look after an old person on a particular ventilator in their home, and the micro-credentials. And the utility of that approach, of course, is that you don't have to train someone for all the things they may possibly have to do. You train them specifically and credential them for narrow tasks. So the answer to your question, Nick, is I would focus on primary and community-based care, and I'd focus on the business models, because quite frankly, the current business models are not only constraining, they're unfair, they're unsustainable, and they're unaffordable.
Great, thank you, Des. And look, I'm going to say thank you to all of our panelists. That's been a really great discussion, and I hope it leads on well to the other roundtables that are coming up over the next day or so. I'm going to hand back to you, Ivy, to see whether there's any comments you wanted to make in closing. Thanks again, everyone.
Thank you so much for colleagues in Australia and New Zealand for really kicking off this series of roundtables so well. Very stimulating conversation. There's so many comments in the chat. We will let everybody go on time, but if anybody would like to stay, I'm quite happy to keep things open. Just a word that our next country panel will be the UK. For those of you who'd like to get up early in the morning in Eastern Daylight Time, that is 5 a.m. I will be up, so please come and be up with me. And I mean, it's a different time zone for everybody else. Sue, we will absolutely not allow you to do that because it's 2 o'clock in the morning for you. So no worries. We do record to the cloud, so I'll be posting this for anybody. So if people missed it and would like to pick it up, it will be there already. So yes, so the next one up is UK at 5, the US at 11 a.m. and then the Canadians will sweep it in as a curling metaphor. We will bring the rocks in, and at 4, I think, is the time that we're doing it. But you know, don't listen to me. Look at the registrations. That's where we're going to do it. So thanks, everybody. I'm going to stop the recording. If anybody would like to stay and chat, I'm happy to do so.